citizens and dear friends. I'll be talking to you on role of anti-VEGF in the management of inflammatory new vessels in uveitis with case examples. The outline of my talk includes the introduction, the role of anti-VEGF agents, what are the imaging modalities we can use to document and monitor the new vessels and management.
Hold on.
1 minute.
This slide is something different actually. This is a different slide. ये वाला नहीं, जो मैडम का है ना?
This one. Thank you. Sorry. Imaging modalities and management options with case examples with take-home points. In uveitis, we have inflammation which lead on to ischemia, which in turn causes new vessel formation. So next treatment includes anti-inflammatory agents and also the anti-VEGF agents. The sight-threatening vision complications in uveitis, which are VEGF-mediated, includes cystoid macular edema, choroidal neovascularizations, and retinal neovascularization. Anti-VEGF in uveitis is primarily indicated if the patients have macular edema, choroidal neovascular membrane, retinal neovascular membranes, and cases were intolerant to systemic steroids or refractory to therapy. Anti-VEGF agents is combined with systemic steroids or immunosuppressive agents to achieve the disease quiescence in uveitic eyes. Intravitreal anti-VEGF agents per se can cause increase in inflammation in pre-existing uveitis, or it can cause reactivation of diseases like VKH and sympathetic ophthalmia. So we have to cautiously use these agents in inflamed eyes. Intravitreal VEGF level in uveitis patients treated with uveitic macular edema with bevacizumab, the results are well known in the literature. So VEGF plays an important role in the pathogenesis of uveitic complications such as cystoid macular edema, choroidal neovascularizations, and retinal neovascularization. The blockage of VEGF has not shown to have anti-inflammatory effect. Coming to the new vessels, in the anterior segment, they can present in the pupillary margin and the periphery of the iris. They can cross the scleral spur. They are thin, arborizing and fenestrated vessels, poor blood aqueous and blood retinal barrier leading on to leakage of the vessels. Coming to the imaging modalities, the anterior segment new vessels can be documented with anterior segment angiography, the wide field fundus photography, and we also have angiography like fundus fluorescein angiography, indocyanine green angiography, and also OCT and ARCTA to study the choroidal changes. Coming to the management, when the patients have neovascularization with uveitis, we see whether it is associated with inflammation or without inflammation. If with inflammation, the preferred drug will be an anti-inflammatory therapy in the form of corticosteroids. They can be given in the form of topical, systemic, periocular, or intravitreal steroids. Topical non-steroidal anti-inflammatory agents also can be used as an anti-inflammatory agents. If inflammation is significant or severe, we use systemic immunosuppressive therapy. The severe cases like Behçet's and ANCA-associated vasculitis, those kind of conditions, we use biologics. And anti-VEGF agents, the preferred ones are bevacizumab, ranibizumab biosimilars, and abelacicep. Next, the brolucizumab and faricimab can increase in intraocular inflammation in uveitic eyes. Without inflammation, if they have neovascularization, anti-VEGF will be the first drug of choice, followed by laser photocoagulation. We'll move on to the case examples. A 30-year-old child presented with left exotropia. Fundus examination revealed bilateral healed toxoplasmic retinochoroidal lesions. We made the diagnosis of toxoplasma based on the serology. OCT was performed over the lesion, in which we can see the choroidal neovascular membrane with intraretinal fluid. Child received injection bevacizumab, and we could see the resolving SRF in this child. Now the child is 7 years old, has recently had reactivation of toxoplasmosis. Subsequently, the child received 2 more injections of bevacizumab. OCT was monitored. 1 year later, again reactivation of the CNVM with SRF. Here, the child received 3 doses of abelacicep, following which there was resolution of the CNVM in this child. The next case is a 57-year male diagnosed case of idiopathic panuveitis with secondary glaucoma presented with prominent vessels in the right eye, where we could see the inflamed iris vessels in the anterior segment of the eye. We stepped up the topical and systemic steroids, following which we could see the resolution of the inflammatory vessels in the anterior segment of the eye. He presented 2 months later with neovascularization of the iris in the left eye, with increase in intraocular pressure. He gave intracameral bevacizumab injection. When we did a tear cytokine analysis, we noticed increased MMP9 iris vessels treated with steroids. In June 2022, we also noticed increased VEGF levels. At that point of time, in addition to the steroids, we also used anti-VEGF agent in this patient. Next case is a 13-year-old girl referred as a case of a bilateral panuveitis, where we could see the neovascularization on the disc in the left eye. Here we see the disc leak, diffuse perivascular leak with neovascularization, found pattern of leakage with disc hyperfluorescence, diagnosed have a Behçet's uveitis. This child received systemic steroids, immunosuppressive therapy with methotrexate and injection adalimumab, following which we could see the resolution of the inflammation and disappearance of the new vessels in both eyes. Next case is a 16-year-old boy presented with history of sudden onset of defective vision in the left eye, history of travel. He also gave history of fever 2 days back. And on examination, we could see a bilateral retinal vasculitis with classical candlewax drippings were seen, hyperemia of the disc, periphlebitis is seen, and neovascularization of the L's seen in the right eye, where we could see the neovascularization elsewhere. On close follow-up, we could see in addition to the vasculitis, you can also see a focal areas of retinitis in the left eye. OCT shows hyperreflectivity with aftershadowing. This is an FFA picture showing the disc leak, staining and leakage from the vessels, neovascularization with capillary non-perfusion areas. On investigation, this child diagnosed have increased serum ACE level suggestive of sarcoidosis. In addition to that, OX2 and OX19 was also positive on wheel Felix, suggestive of a rickettsial infection, which correlates well with the clinical findings of focal retinitis in the left eye with candlewax drippings in both eyes. So we made the diagnosis of posterior uveitis secondary to sarcoidosis with rickettsial post-fever retinitis. We treated the patient with doxycycline and oral steroids, did the targeted laser photocoagulation for the capillary non-perfusion areas. Subsequently, we started the patient on systemic methotrexate therapy. We also have done the tear biomarker analysis. In that, we noticed increased ICAM and MMP9 in the right eye. In the left eye also had both MMP9 and ICAM1 was elevated. Subsequently, there was a persistence of inflammation. When we did that, at that point of time, increased MMP9 was high. We have to put the patient on intravitreal steroid Osidex implant, following which there was resolution of the inflammation. Here, the clinical persistence of inflammations correlated with increased inflammatory markers in the tears. The next case is a 45-year-old female presented with both eye laser PDR with florid NVD and vitreous hemorrhage, diagnosed of a syphilitic retinal vasculitis. Patient was partially treated with syphilis elsewhere. Here we could see the florid NVD with vitreous hemorrhage in both eyes, disc hyperfluorescence, perivascular leakage with block fluorescence corresponding to the areas of the vitreous hemorrhage on FFA. Investigated both specific and non-specific, that is treponemal and non-treponemal tests, both TPHA and RPR was positive. Diabetic status was under control. We referred the patient to the infectious disease specialist, restarted the patient on antisyphilitic treatment. Patient also received doxycycline, and you could see the resolving panuveitis with vitreous hemorrhage in this patient. Started on oral steroids, and patient received intravitreal bevacizumab injection to both eyes, following which we could see the resolving NVD and vitreous hemorrhage in both eyes. subsequently underwent 3 more injections of anti-VEGF into the right eye and 2 injections in the left eye, along with targeted laser was done for the right eye, and oral steroids was continued. So resolving uveitis with neovascularization we saw. We also have done the tear cytokine correlation, which correlated with decreasing MMP9, ICAM, and interleukin 17A and TNF of this patient. It was high in the presentations. Following treatment, there was a resolution. Can I take 1 minute more? 1 minute more. VEGF level also we can see it's gradually declining. Here is a case of a 32-year-old lady presented with defective vision and flow tests, diagnosed of a granuloma on ATT and systemic steroids. Here you could see the hyperreflector in the outer retinal layer with hyperfluorescence on ACTA. This particular patient received ATT steroids. The granuloma was regressed. 4 years later, patient presented with defective vision in the left eye, where we could see the neovascularization on the surface of the granuloma, which you could see it on ACTA. However, there was no activity of the granuloma. So, the granuloma was vascularized without reactivation of the uveitis. Patient received 2 doses of anti-VEGF without steroids, following which we could see the resolution of the new vessels on the surface of the granuloma. Here again, we did the tear cytokines which correlated with increased VEGF level with the granuloma, vascularized granuloma, following which there is regression of the vessels and decrease in the VEGF level from the tears. 34-year serpiginous like choroiditis. Fundus autofluorescence shows hypo with hyper-autofluorescence. ACTA shows the choroidal neovascular membrane. So this is the OCTA findings where we noticed deep spacing between the larger vessels were increased, deep vessel density was decreased, and also we have seen the capillary free zone corresponding to the areas of the choroidal neovascular membranes. The deep vessel density had the highest area under curve compared to the other vascular parameters. So capillary free zone and increased active CNVM compared to the normal eyes. This is a summary of the cases. We managed majority of the cases. In addition to the anti-inflammatory, anti-VEGF agent was used. To summarize, in uveitic new vessels, we need to treat the underlying disease. Either it's infective or inflammatory, we have to treat them with appropriate anti-inflammatory therapy. Inflammatory new vessels respond well to anti-VEGF therapy. Clinical imaging and biomarkers can correlate with the disease activity. Capillary free zone acts as a significant parameter to distinguish between the normal and choroidal neovascular membrane on ACTA. Each case, we need to tailor-make approach to treat inflammatory new vessels. Thank you for the opportunity. Thank you for, these are my acknowledgements, and thank you for the attention.
Thanks, Malini, for this wonderful 6 cases you shown. But the message should go that in inflammatory disease, only if you have new vessels, then only you give this trial of anti-VEGFs. Otherwise, inflammation does subside with anti-metabolites.
Anti-inflammatory therapy itself.
So those still remain the mainstay of treatment. Only if, suppose you get a treatment naive first-day patient who has all these features, will you start steroids alone or you will still add anti-VEGFs?
We start the steroids, see the response, and then add anti-VEGF if still the inflammation vessels are persisting.
Yeah, because I have seen patients who respond to steroids alone also.
Yes, I have seen one case, Bechet's case, where responded to steroids and anti-inflammatory therapy.
Yeah. So anti-VEGFs are not the mainstay, but only if they are complicated by formation of new vessels.
Associated neovascularization, then we give anti-VEGF.
Mahesh.
One probable exclusion would be an infective granuloma, because tubercular granuloma you would give probably intravitreal moxifloxacin plus an anti-VEGF. That works. Even in the presence of an active inflammation, you can do that.
Yes, in active TB granuloma with the vascularization, we inject anti-VEGF along with moxifloxacin as like SIRS.
I think one major contraindication for any anti-VEGF is pre-existing inflammation. That's what we, retina people follow. We tend to avoid it, especially if there is early pre-existing inflammation. So have you ever seen worsening of the inflammation? Yes, the vascular component has come down, but post anti-VEGF in any of these patients, did you see worsening of the inflammation?
We did see in other patients, not in this, but they have minor flare-up like vitritis, and they settle down with stepping up of the corticosteroids.
Systemic or topic?
It depends upon the type of the uveitis, and most of the times increasing the frequency of the topical along with stepping up of the oral steroids.
There's a subtle difference between an inflammatory CNVM and a CNVM in a post-inflammatory eye with recurrence. What would the indications to be to make out those two?
So inflammatory CNVM is majority of the time it's type 2 kind of a CNVM, and in an OCT, in addition to the CNVM, we also have other inflammatory signs like presence of posterior vitreous cells, intraretinal fluids, subretinal fluids, and increased choroidal thickness, or in case of a granulomas, that will help us to differentiate from other entities.
Okay. So just to add to that, one of the points where you would give an anti-VEGF very early is if it's a very juxtafoveal CNVM just abutting the fovea, and on Octa, if you can see actually an advancing edge towards the fovea, you would be have a low threshold of giving anti-VEGF very early, even if it is in the inflammatory stage.
Any other questions from the audience?
And any choice of anti-VEGF agents?
I do not have any financial interest,
But any agent should suffice.
Anything they respond well, but if it's persistent, recurrent, then they respond better to aflibercept.
Would you want to avoid a biosimilar in these? I'm sorry, I think I'm in the wrong hall. But anyway.
Yes, preferable. We have seen quite a few patients with flare-up occurrence of inflammations. We generally tend to avoid.
Madam, the reason for neovascularization in these uveitic eyes is that inflammation is not under good proper control.
Yes.
But with an anti-VEGF, definitely it will disappear. And do you also hike up, along with the anti-VEGF, always do you hike up the dose of the immunosuppression for these patients, so that because the next time the neovascularization is going to come, or if we are able to understand that the immunosuppressive dose is not good enough, is after 6 months, because the next neovascularization will come after 6 months. So will you always hike up the dose of immunosuppression along with the anti-VEGF? Because some of the cases, just by hiking up the immunosuppressive dose, the neovascularization disappears.
Yes. Definitely, the basic mechanism itself, the inflammation is not kept under control, the ischemia and then the new vessels. So definitely anti-inflammatory therapy not only controls, will prevent the recurrence of new vessels. I agree.
So next.
And more importantly, what we find it useful in posterior uveitis, targeted laser photocoagulation, if there is a CNP areas, FFA-guided laser treatment, definitely plays a role in preventing the recurrence of new vessel occurrence, in addition to inflammation.
So thanks, Dr. Padmamalini, for some insights into inflammatory new vessels and uveitis.